Okay, now we can start. So, I would like to focus on the future developments in structural interventional cardiology with focus on the mitral and tricuspid valve. It's a little bit like to look into a glass ball. Most of the techniques you will see in the next few minutes a little bit are science fiction or disruptive technologies, and the most thing what you have to know is that only 5 to 10% of all the disruptive stuff will have an impact in our clinical routine. And I have no conflict of interest, and I would like to start with mitral regurgitation and percutaneous treatment of mitral regurgitation. The most of you know that the age is most important factor for the prevalence of mitral regurgitation, and that is one of the latest studies published by Enrique Serrano a month ago in Lancet, and you can see very nicely in the group of an age of more than 75 years, we have a prevalence of 5% of mitral regurgitation. And on the right side, you can see the impact of mitral regurgitation on the survival in this group compared to patients without a mitral regurgitation. And if you look a little bit closer in the data, then you can see, particularly in the group with a left ventricular ejection fraction lower than 50%, it's a dramatically reduction of survival after 10 years. But the key problem, and especially also a key problem for the cardiac surgeon, is that in the group of 70 to 8 years, the most of the patients, they need surgery. During the following reasons, heart failure is one reason, diabetes or cardiovascular comorbidities, which have an impact on the outcome after a surgical procedure. And the question is, do we have an unmet need? Yes, we have an unmet need because we have an increase of morbidity, mortality, and hospitalization caused by mitral regurgitation, and only 47% of the patients with mitral regurgitation underwent surgery, and the most of the patients got surgery for primary mitral regurgitation. And then we have the impact of the age, particularly the group of older than 70 years old, they need surgery, and the group which has more than 2 cardiovascular comorbidities, they need surgery. And that is the reason why we need alternative therapeutical options in the future. That is what you know. We have 2 main causes for mitral regurgitation. It's the primary MR and the secondary MR, and the main indication for interventional therapy is the secondary mitral regurgitation. And what is the problem? We have a reduced LV function. We have mostly a high risk score. The most of the patient has an impaired renal function. Pulmonary hypertension is a problem, right heart failure, frailty, and in the future, there are candidates for an LVAD implantation or for heart transplantation. And if you look at the guidelines, we have the ESC guidelines, the AHA guidelines, and for the daily practice, I recommend the expert consensus guidelines with more detailed information how we can treat these patient groups. And one of the best publications is the ACC recommendation for the pathway for the management of mitral regurgitation. And here's a clear definition from a heart valve team. It's a new definition that means we have a valve expert that can be a surgeon, that can be a cardiologist, and can be an anesthesiologist. We should have imaging experts, surgeons, interventionalists, anesthesiologists, and the nurse care team. And that is the first definition of a decision chart which has an impact for shared decision making. That means the following points like etiology, symptoms, LV function, associated conditions or comorbidities, risk assessment, functional assessment, and shared decision making are the most important things what we should respect during the decision process. So now we came to the mitral valve interventions, and we have 3 types: coaptation devices, annuloplasty devices, and transcatheter mitral valve replacement. And that is what you know. On the right side, the coaptation devices, valve replacement, and the percutaneous annuloplasty devices. And I would like to start with the coaptation devices. We have currently 2 options. The first option is the well-known MitraClip, and we have a new one that is from the company Edwards, the Pascal system. It's the same procedure, a little bit